So good afternoon, everyone. I believe you're 2 hours ahead of us from the UK. Just to introduce myself, I'm Kieron Hickey. I work in the Sheffield Haemophilia and Thrombosis Centre in the United Kingdom, and Sheffield is in the northern part of the country. At the minute, we're quite cold, a bit damp. Recently survived about 2 weeks of snow that wouldn't disappear. So we have quite a mild climate. Myself personally, I've worked in the area of hemostasis for the past 24 years. Pretty much my only professional job has been working in coagulation. And I'm grateful for the opportunity today to talk about the coagulation cascade and screening tests. I was doing a little bit of Googling on Zambia and the UK and our connections, and we are both part of the global hemostasis community. The World Federation of Haemophilia issues an annual global survey looking at the identification of haemophilia patients across the world and their access to care, identifying patients with haemophilia, von Willebrand's disease, rare factor deficiencies, and inherited platelet disorders throughout the world. And you can see both the United Kingdom and Zambia are representative countries. And in fact, Africa is the second largest contributor to this WHO report yearly. And they have some excellent data on the trends we're seeing in the diagnosis of bleeding disorders. And the trends are good. In the past 20 plus years, the ability and access to coagulation tests to allow better identification of patients with bleeding disorders has improved. And we're hopeful that we will continue to see improved diagnosis and hopefully access to care to patients with significant severe bleeding disorders. But the main part of my talk today is just going to talk about the coagulation cascade, the separate intrinsic, extrinsic pathway, and then discuss the main screening tests we perform, the PT, prothrombin time, deactivated partial thromboplastin time, and the fibrinogen. Now, historically, if you're joining, that's fine. I've just started to lecture, so you haven't missed much, just a brief introduction. But you might want to put your microphone on mute if you can. So people have been fascinated.
To interrupt you. Everyone, please put your microphones on mute. Yeah, thank you.
No problem. So people have always been fascinated by coagulation. Why does blood that leaves the body clot? Aristotle proposed that when blood left the body, the temperature change caused it to congeal. But as scientific discoveries evolved, with the discovery of thrombin, platelets, fibrinogen, and calcium, we started to get a better understanding of coagulation and how it worked. And it was in 1905 that Paul Marowitz merged all the components and developed the classical theory of coagulation. But it was later when Dr. McFarlane proposed there would be a coagulation cascade, and Davies and Ratnoff were slightly behind him, and they proposed there was going to be a coagulation waterfall. And because Dr. McFarlane was first, the coagulation cascade stuck as the main term to describe how blood clots. And it is a quite complex process. It involves a series of enzyme zymogens, so inactive precursors, being activated. And they divided coagulation cascade into two arms, the intrinsic and the extrinsic pathway. And it's an amplification system involving relatively few initiating activating substances. This means that when there's vessel damage, you can rapidly activate the coagulation system. And it has a series of serine protease enzymes and cofactors sequentially activating their targets. So most of the coagulation factors exist in an inactive form. They are essentially inert. But by cleaving one or two peptide bombs, they become activated and then can activate their target. And what it means, you can get rapid activation of thrombin, which is the central player in coagulation. Thrombin in turn will convert fibrinogen, which is soluble and a monomer, into fibrin, which is insoluble polymer. And this fibrin will enmesh in the platelet plug at the local site of injury, stabilizing the clot and preventing further blood loss. And that is a basic principle of how blood clots. And we will see in many textbooks talking about hematology or hemostasis, diagram similar to this in one way or the other, showing the coagulation system. And you will see often it's depicted as an extrinsic system, an intrinsic system, and then this common pathway. And are often designed to help explain how the coagulation test we perform relates to the clotting factors we see. So if you're unfamiliar with the cascade, there will be Roman numerals like factor 7, factor 9, factor 8 depicted. Their activated form is indicated by a small a, and there'll often be arrows indicating which is the direction of travel of clotting. Some parts will indicate where calcium or phospholipid is required for the reaction to occur. And when I mentioned thrombin being a central player, these dotted arrows are indicating the feedback loops where once thrombin is activated, it feeds back into the cascade to activate some of the other clotting factors. And when you have here factor 8 and factor 9, they are needed to work together to activate factor 10, and factor 10 and 5 is needed to work together to activate prothrombin, with the final aim, like I mentioned, to form a stable fibrin clot, with factor 13, which I'm not going to get into today, helping to stabilize the fibrin clot once it's formed. Now, we said there's the intrinsic, extrinsic system, but these ideas developed alongside the laboratory investigations which helped explain hemostasis. And I just wanted to briefly talk about the actual physiological pathway in vivo is slightly different. And by talking about this, it will help explain some of the weaknesses of some of the clotting investigations we have and some of the limitations in the results they generate. So this is just a cartoon of how blood clots inside the body. So if you cut your arm, you have damage to the vessel wall, it will expose tissue factor at very, very small concentrations, which will combine with factor 7, which is the only clotting factor that partially exists in its active form. So this can accelerate clot formation. This combination of tissue factor and factor 7 will partially activate factor 10 to 10A and factor 9 to 9A. And this is known as the initiation phase of coagulation. You then get the amplification phase. You see factor 10A will convert a small amount of prothrombin to thrombin. This thrombin then has numerous roles, one of which is to activate platelets. Platelets undergoing what's known as blebbing, where the phospholipid surface is exposed by a change in shape of the platelet. Thrombin will also activate factor 9A, factor 9 to 9A, and factor 8 to 8A. These then will localize on the platelet because they require phospholipids to function. And the same occurs for factor 5 that requires phospholipid for its function. Then we get this propagation phase, which is the final step, where the factor 8 and 9, which is known as the 10A's complex, converts a huge amount of factor 10 to 10A. The factor 10A and 5A in the prothrombinase complex will convert prothrombin to thrombin, with thrombin converting soluble fibrinogen to insoluble fibrin to form a stable clot and stop bleeding. So although we have our schematic for coagulation, it is slightly different to in vivo coagulation. So I'm just highlighting this fact, which might explain some limitations of the tests we're talking about. And while I'm here, there's an excellent document, Diagnosis of Haemophilia and Other Bleeding Disorders. It's currently in the 2nd edition. The 3rd edition, which I've collaborated on some parts of, is under review and should be released later on this year. But it gives a really good introduction, not only to the diagnostic tests, but how they can be performed. primarily focused on diagnostic tests in the water bath, but it is an excellent document which is available from the WFH website. Now, before you can perform any investigations, obviously venipuncture is required. A sample needs to be taken from the patient, and the quality of the laboratory results you generate is dependent on the quality of the blood sample you receive. So in the United Kingdom, and I imagine it's common or the same across the world, samples are taken into 9 parts blood to 1 part anticoagulant. The anticoagulant of choice is trisodium citrate, and it should be at a concentration of 0.109 molar or 3.2%. And the primary role of trisodium citrate is to chelate or bind to calcium, removing it from the patient's blood sample. And because that calcium is removed, clot formation is inhibited. In the UK, we have access to tubes from Briner, from BD, or from Starsted, and they're the common tube types we use, all with a similar system of venipuncture to draw the sample into the tube, which then can be processed for testing. Now, there's lots of pre-analytical variables which can affect the quality of our laboratory results. So when a patient can have a difficult or traumatic phlebotomy, in that it's difficult to draw the blood sample from the patient, they have small veins or damaged veins, often shear stresses can affect the sample while it's drawn, potentially activating some of the clotting factors, which can affect the laboratory tests we're going to do later. Additionally, if it's a difficult blood draw and you don't get an appropriately filled sample, this can be problematic when you come to test the patient. Because these are enzymatic reactions, then time delays in processing can affect the result. So invariably, there is a time window. For APTTs, it's usually 6 hours. However, if the patient is on unfractionated heparin or low molecular weight heparin, then these samples should be processed within 4 hours. But often the stability window is locally dependent because temperature and higher temperatures can affect the stability of the clotting factors. So usually locally derived stability windows are established. When you have an underfilled sample, you can have air spaces in tubes, which can be problematic. Tube type in Europe, we've moved to essentially to a plastic tube, but I know glass is still available. And all samples should be centrifuged at a minimum 1700 G or around 3,500 revolutions per minute for 10 minutes to get a citrated plasma, which is sufficiently free of red blood cells and platelets to allow us to do our routine coagulation investigations. As a consequence, the sample variables can be, the samples can be clotted because the patient had a difficult phlebotomy and actually the clotting factors were activated and overcome the trisodium citrate to remove the calcium, and a clot occurs anyway. So it's important if you're doing laboratory investigations and you get abnormal clotting results, just to check, you can use plastic or wooden sticks to pull out within the blood tube to see if you can identify a blood clot that's already been formed, which will consume clotting factors and give you an inaccurate laboratory result on the patient. You can also get partial activation of the clotting samples because some of the clotting factors are activated but are not enough to clot the sample, but enough to affect the APTT or the PT you're investigating later. Difficult phlebotomy can cause hemolysis, where there's lysis of the red blood cells, which causes the citrated plasma to take on a red color. And lipemia can be an issue which can be overcome by higher levels of centrifugation. I haven't got the opportunity to go into detail about the effects of polycythemia on clotting today. There are two excellent guidance documents from the International Council from Standards in Haematology, and these cover blood samples collection and blood sample processing, and they're going to cover all aspects of the pre-analytical conditions which can affect blood clotting, and they're two excellent, straightforward guides from people who are currently working in the field of hemostasis to give you good recommendations. You have Steve Kitchen from my laboratory, Dorothy Atcott from America, we have Sukash Nair from India, a good group with excellent guidance. So when I'm talking about hemolysis, you'll probably seen samples that look like this. A well-taken venipunctured sample will be appropriately filled and will have a slight yellow color. But you can see as the phlebotomy becomes more difficult, you can end up with hemolysis of the samples, which can significantly affect the clotting results we generate. Within this guidance, they do make a clear recommendation that you should check for the presence of in vivo hemolysis, and this is preferably using an automated system for consistency. However, it was only in the past few years our laboratory took on an automated system, and in the past it was visual inspection of the sample tube to identify where samples are adequately unhemolyzed, but the point where hemolysis can affect the clotting results. And the test that's most often affected significantly by hemolysis is the APTT. And I've just got a couple of slides to talk about what effect hemolysis has on the activation partial thromboplastin time. So this is some work we did in our laboratory. We had 60 samples come in at different time intervals that were hemolyzed. These were rejected by the laboratory and we asked for a repeat sample. And for these 60 hemolyzed samples, we would get a repeat sample within a 4-hour window, and we would then define this as a hemolyzed pair. And we considered that in that 4-hour window, the changes in the samples wouldn't be due to changes in clotting factors because the time window is so short, but changes would be due to the hemolyzed sample versus the non-hemolyzed sample. And when we performed some APTT investigations, we found that there was significant difference in some of the patient samples above and below our reference interval. So if we look at this graph here, we have our APTT in seconds and the 60 paired samples. This black line here is our upper limit of our reference interval. So above this line, samples have abnormal clotting. Below this line, they're demonstrating normal APTTs. And of the 60 pairs, we saw 12 samples where the APTT changed between the non-hemolyzed and hemolyzed sample. Oh, sorry. If we look at the APTTs in the red circles, you will see that the hemolyzed samples had prolonged APTTs. However, when we had the repeat sample come in, the clotting time was normalized. However, the hemolysis effect is not primarily down to the red color in the sample. It's a much more complicated process which still hasn't been properly elucidated. We believe there's shear stresses activating some of the contact factors like factor 12A, high molecular weight kininogen, factor 9. So you can see some samples in green where the APTT in the hemolyzed sample is shorter. However, in the non-hemolyzed sample, they have an abnormal APTT, which in our laboratory may well then be investigated for an explanation for the prolongation by doing some factor assays. So the key point is hemolysis is a complex process. It can both prolong and shorten the APTT. So best practice is to avoid performing these tests and wait for a non-hemolyzed sample because you're going to get a more accurate reflection of the patient's hemostatic system. And a couple of slides on underfilled samples. So again, we use this BD Vacutane in our laboratory. We have our compacted red cells and then our situated plasma. So the question is it safe to test underfilled samples? Here's some data on the underfilled sample. So this is the INR, the calculation of the prothrombin time used to measure warfarin therapy, a common anticoagulant in the UK, and had an INR of 9.8, which is grossly high, with an activated partial thromboplastin time of 84.2 seconds, also significantly high. However, we can see on the properly filled sample, the INR was much less, and the APTT was 45 seconds, in keeping with a patient on warfarin with an INR in this range, just highlighting to always avoid testing underfilled samples because you get unreliable laboratory results. Now, in the United Kingdom, we're fortunate to have access to a variety of different automated analyzers. At the start of my laboratory career, we were still doing some investigations manually for D-dimer, but the trend in the UK has been more automation, mainly due to higher throughput, reduced sample use, better precision, better variety of laboratory investigations you can perform. But no, my computer has just gone strange. Can you still see?
Yes.
Okay, excellent. We still have a water bath in our laboratory, which we use to perform some coagulation investigations. Invariably, when the automated platform is giving us results we're not quite confident in. But the point being, the tests I'm going to be talking about today can equally be done on automated analyzers, but can also easily be performed in a water bath to investigate patients for suspicions of bleeding disorders. So our setup here is quite common for people doing manual clotting. We have a temperature controlled water bath monitored by a calibrated thermometer. We have timers for monitoring the clotting time, pipettes for aliquoting our reagents and plasma, and an angle poised lamp for giving us the light source to detect the clotting. So I'm going to go into now talking specifically about the three main investigations, starting with the PT or the prothrombin time. It's designed to reflect the overall efficiency of the extrinsic cascade and the common pathway. And as a consequence, it's sensitive to 2, 5, 7, 10. This is why it's used for monitoring warfarin therapy. Warfarin is a vitamin K antagonist, and it will reduce the concentrations of 2, 7, 9, and factor 10. So a conversion of the PT to the INR is the most common way of monitoring warfarin therapy, and can also be used to detect acquired bleeding disorders such as DIC or liver disease. So the prothrombin time itself is a measure of the extrinsic pathway. If this test has been performed in a water bath, you would mix 200 microliters of your prothrombin time reagent with 100 microliters of the citrated plasma of your patient. The thromboplastin reagent itself contains calcium. So when you have a mixture of the thromboplastin and the citrated plasma, all the components of the coagulation cascade are available for clot formation to occur. Upon addition of the citrated plasma, you start a timer and measure how long it takes for the sample to clot. And you will see the reaction following this cascade. The thromboplastin contains the tissue factor, combined with the calcium and factor 7, converts 7 to 7A or binds with the already activated factor 7, converts factor 10 to 10A. This requires the calcium, the phospholipids from the reagent, and factor 5 to convert prothrombin to its activated form thrombin, finally converting fibrinogen, factor 1 in this diagram, to 1A, the insoluble fibrin polymer. And clotting time is roughly between 10 to 12 seconds, but that can be partially reagent dependent. When we're performing this investigations, again, we use what's called the manual tilt tube technique, where you will tilt the tube 3 times every 5 seconds into and out of the water bath as you're monitoring the sample, looking for the fibrin clot to be generated to stop the time and have you a measure of the prothrombin time. A more detailed description of this is in that WHO document I referenced earlier. And there is a variety of different prothrombin time reagents available. For us in the UK, in Sheffield, we are using a material called Innovin, which has recombinant human tissue factor with calcium. These are made in large volumes by a big multinational corporation, Siemens. So it contains tissue factor produced by E. coli or in E. coli, combined with phospholipids, which is a source of thromboplastin, calcium, buffers, and stabilizers. And we reconstitute this reagent in 20 mils of water, and it's stable for several days on board our analyzer, or kept in a fridge and used for manual clotting in the water bath. The key point with prothrombin time reagents, there's really two big distinctions, and it's based on how much phospholipid is in the reagent. There are occasions where a syndrome called lupus anticoagulant, which is associated with antiphospholipid syndrome, can interfere with phospholipid binding and give you abnormal clotting based on the prothrombin time. In those situations, we use a secondary reagent with a higher phospholipid called thrombo-RLS, which overcomes this antibody interference and gives us an accurate measure of the prothrombin time. But it's worth remembering that this lupus anticoagulant can potentially, on rare occasions, interfere with prothrombin time measurements. The second main investigation I'd like to talk about is the activated partial thromboplastin time. This was the second main test developed on the back of the prothrombin time because they found that the prothrombin time or its precursor, the quick test, was inadequate in diagnosing hemophilia A, reduction in the level of factor VIII. So it's a non-specific test of the intrinsic system, and it's sensitive to deficiencies of factor VIII, factor IX, factor 11, and factor 12. Again, it has one slight drawback is depending on the reagent you have available, there's a potential for a prolongation of the clotting time in the presence of antiphospholipid antibodies, as I mentioned for the PT, from lupus anticoagulant, the term to describe these antibodies. And they can cause reagents which are sensitive to antiphospholipid antibodies, in this case, Symphysil, to give you a prolonged clotting time, which may be suggestive of a factor deficiency, but in fact is caused by lupus anticoagulant. In our laboratory about a decade ago, we switched from a sensitive to an insensitive APTT. So we now use Actin-FS from Siemens, which has a higher phospholipid concentration, so has much, much less interference from antiphospholipid antibodies, which means if you're using such a reagent or have access to such a lupus anticoagulant insensitive reagent, when you see a prolonged clotting time, you know the patients aren't on anticoagulants. It gives you a good indication that they may have a low level of factor VIII, 9, 11, 12, and avoids the consideration of antiphospholipid antibody interference. Now, again, the APTT can be performed equally on automated platforms or in a water bath. If we were performing the APTT in the water bath, we would have our reagents preheated to 37 degrees C. We would incubate for 1 minute prior to testing the citrated plasma from the patient, 100 microliters in a small glass tube. We will then add our APTT reagent, which contains phospholipid, and you get contact activation because APTT reagents within them either have something like silica or ellagic acid, which provides a negatively charged surface for contact factors like prekallikrein, high molecular weight kininogen, or factor 12 to become activated on. We incubate the mixture of citrated plasma and platelet substitute for 3 minutes, and this is timed on a stopwatch. And in that time, the negatively charged surface in the reagents allows contact activation and activation of coagulation down to the level of factor 9. However, unlike the PT, this reagent contains no calcium, And as such, it gets paused at the activation of factor 9. But then when we add the 100 microliters of pre-warm calcium and start our timer and monitor during tilt tube technique for clot formation, you see activation of coagulation down the cascade, activation of prothrombin to thrombin, and then fibrinogen to fibrin, and then we stop the stopwatch. And again, clotting times are reagent dependent, but you'd expect to see normal clotting times of around 25, 30 seconds in a patient with normal levels of clotting factors. Now, in the UK and Europe, there's a wide variety of different reagents, and they all differ slightly in their performance. You may well see a reagent here that you have available in your laboratories. And this is data from what's called UK NetQuas for blood coagulation, a UK-based external quality assurance provider. They send a lyophilized, freeze-dried material to all their users. They will then reconstitute that reagent and perform the APTT in the method that they commonly use in their laboratory, send the results back to UK NetQuas, who will review and compare the laboratory's performance against all the other users. And you find for this material which had a normal clotting time, generally speaking, you can get very good agreement irrespective of the APTT reagent in a normal sample, with 98.3% of people identifying normal clotting in this tube, or in this sample, 5%, 5.7% CV, and a few people defined as out with consensus. So this is people who are using a particular reagent like Siemens Actin or Hemasil APTSP, whose performance is outside the statistical analysis for normality. So even with automated analyzers, you can still get a slight variation in performance, but generally speaking, most APTT reagents are quite reliable and can be used to diagnose bleeding disorders. Here is a table looking at the concept of APTT sensitivity. So if you're going to be performing routine clotting investigations, it's important to recognize the limitations of these tests. So this graph here is the APTT measured in seconds and the clotting factor level on the second axis in IU per deciliter. If we look at the green triangles, and this is with our reagent Synthosil performed on a Sysmex autoanalyzer, patients with extremely low levels of factor VIII, so severe hemophilia, will invariably have a prolonged APTT of 60 seconds plus. However, as the concentration of the clotting factor increases, we need to be aware with this particular reagent that patients who have clotting factor levels of around 40 IU per deciliter for factor VIII may well have on occasion a normal clotting time indicated by the green diamond below this purple line, which is the upper limit of our normal reference interval. And it's the same for factor 9, highlighted by the white squares used to diagnose hemophilia B. That again, with levels around 10 IU per deciliter, you would expect to see a significant prolongation of the APTT near 50 seconds, 60 seconds. However, you can also see normal APTTs in patients with low levels of factor 9 at around 18 IU per deciliter, which with this particular reagent can give you a normal clotting time. And if I would move on to factor 11 and factor 12, again, the graph is showing the APTT versus the clotting factor level, with the upper limits of normality for our reference interval highlighted by the green line. Patients with low levels of factor 9, the white diamond, should see a significant prolongation of the APTT, but it's also true that you can see normal clotting time in some patients with factor 11 levels of around 33, 34 IU per deciliter. And for factor 12, again, you see prolongation of the clotting time when they have low levels of, in this case, on this diagram, of around 18 IU per deciliter. When the clotting factor levels of factor 12 are much lower, you can see a dramatic prolongation at 70, 80 seconds. However, it's worth remembering and acknowledging that you can see normal levels of factor 12 when the clotting factor is around 20, 25 IU per deciliter. And we know that although you see prolonged APTTs with low levels of factor 12 doesn't cause bleeding. This is one of the artifacts of these laboratory investigations we have with the APTT that will give you a prolonged APTT, but when you identify it as a low level of factor 12, that isn't associated with a bleeding syndrome in the patient. And part of the reason is this acute phase effect. So we've looked at the coagulation cascade, and it's a series of enzymatic reactions. So here's an example of a carrier of haemophilia B, and they have a factor 9 level of 35 IU per deciliter. However, the APTT was 32 seconds within our reference interval of 25 to 35. However, the APTT had been prolonged on 3 previous occasions with the same reagent. So we've had a prolonged APTT 3 times. The 4th visit, the APTT is normal. And when we measured the factor 8, it was extremely high at 280 IU per deciliter. And what we have is factor 8 is an acute phase protein. It can get increased in pregnancy. It's increased in stress. And an increase in one clotting factor can mask the low levels of another clotting factor, particularly for factor 8 and 9, and can normalize the APTT. So if I go back to this diagram of how the APTT works, we have a low level of factor 9. However, due to the significantly higher concentration of factor 8, the clotting time generated ends up within the normal reference interval. So we had the low level of factor 9 masked by the elevated factor 8. And lots of people have done work on what they call the responsiveness of the APTT. So identifying how sensitive the various APTT studies are to low levels of factor 8 to diagnose haemophilia A, low levels of factor 9 to diagnose haemophilia B, low levels of factor 11 and low levels of factor 12, because when you perform an APTT, you want to be sure you understand what that clotting time is telling you, but also what that clotting time can't tell you about a patient's risk of bleeding. So this is some work by Pierre Toulon from France, and he was looking at 5 common APTTs, 2 from Hemocil Werthen, APTTSP, and APTT Synthesil, a Stego analyzer, and 2 Trinclot from Trinity. And he established that he would see, using spiking studies, the APTT with this reagent would be abnormal above the upper limit of reference interval when the factor 8 clotting level was less than 47 IU per deciliter. Synthesil was giving you a prolonged APTT at 38 units of factor 8, and the Stego one was at 45, Trinclot at 34, the second Trinclot at 39 IU per deciliter. So just indicating when you see a prolonged APTT is important to know, because some reagents, and this is for factor 9, have quite poor sensitivity to factor 9. So this Trinclot reagent would only give you an abnormal APTT when the factor 9 was at 18 IU per deciliter or less, indicating that quite often it may miss mild factor 9 deficiencies, which could, in a preoperative situation, miss a significant reduction in factor 9, which could cause bleeding. And another common reagent is Actin-FS, as I mentioned, a reagent we use in our laboratory. And on average, we would see an abnormal APTT with factor rates of 58 units per deciliter, factor 9 of 55 IU per deciliter, factor 11s of 82, factor 12s of 91. So we're quite confident that we should be able to pick up the majority of mild, moderate, severe haemophilia A's, mild, moderate, severe haemophilia B with our APTT reagent given prolongation of the clotting time at these clotting factors. However, in this study, they did identify on occasions patients with very low levels of factor 12 given a normal clotting time, indicating the enzymatic reactions can cause this acute phase effect where low levels of one clotting factor can be masked by another. So it's important, as I mentioned, to recognize the limitation of the tests when you're investigating a patient's bleeding risk, because at the end, there's two parts. There's a laboratory investigations, there's a clinical phenotype in the patient, and best practice in hemostasis is the combination of the clinical picture for the patient, their history of bleeding, their family history of bleeding, alongside the laboratory investigations to make a diagnosis within a particular patient. And this is just reinforced again in this document, which was released in 2020 from the World Federation of Haemophilia. And this section I'm highlighting is lab diagnosis and monitoring. And they just reinforce the point that normal screening tests cannot exclude the possibility of clinically relevant bleeding disorders being present. And for patients with mild haemophilia A and B, the APTT results within the reference range should not be used to rule out the presence of them. This is a UK document talking about the diagnosis of another common bleeding disorder, von Willebrand's disease. And in this, they suggest a diagnosis of von Willebrand's or acquired von Willebrand's disease, a much rarer event. Normal APTTs can't exclude their diagnosis. So if you suspect von Willebrand's disease, further investigation should be performed regardless of the APTT. So if there's a family history or severe clinical picture of bleeding in the patient. And talking about reagent sensitivity, that APTT should be sensitive to factor rates at 30 IU per deciliter. So any APTT that's being used to investigate bleeding disorders should give a prolonged APTT at factor rates at 30 IU per deciliter. And for the majority of reagents, so the ones you may be using in your laboratory, there will be data out there in the published literature to give you some information about your reagent sensitivity. I mentioned factor 12. This is a screenshot of our results we issue on our patients. This patient had a prothrombin time of 9.9 seconds, which was normal, but their APTT was grossly prolonged at 158.3. Our reference ranges are indicated to the right, so normal APTTs were from 20.2 to 28.5 seconds. And when we did our laboratory investigations, we established it had a low level of factor 12, so extremely low, virtually unmeasurable, but just showing you that although you can see grossly prolonged APTTs, when it is identified as a factor 12 deficiency, this isn't associated with a bleeding risk in a patient. Now, it's not only the case that prolonged APTTs are caused by inherited factor deficiencies. I've already mentioned factor 8 and 9, 11 and 12, but you can see prolonged APTTs in prekallikrein, high molecular weight kininogen, factor 2, 5 and 10 deficiency. But also you can see prolongation of APTT in lupus anticoagulant. I'm just going to have a couple of slides on that in a moment. Vitamin K antagonists, we mentioned warfarin earlier, but also a variety of different anticoagulants like the heparins, unfractionated heparin, low molecular weight heparins, and available in the UK, Europe, North America, and maybe available in your country. I'm not sure about the regulatory system. Thrombin inhibitors and 10A inhibitors, and more recently some newer 11A inhibitors are developed, which can cause a prolongation of APTT, which can make the interpretation of an abnormal APTT difficult in patients. So it's always best to get a full clinical picture of the patient's anticoagulant status before you do the investigations, because that can help inform your interpretation of your laboratory results. But I mentioned lupus anticoagulant, these antiphospholipid antibodies, which can interfere with clotting times. This is a graph showing the same patient sample tested here on the left of my screen with Synphysil, and you can see they invariably have longer APTT. The darker bluer line indicates the upper limit of normality for our reference range. So all these patients have an abnormal APTT. In our laboratory, they would have had, if they were preoperative, have investigations for factor 8, 9, 11, and 12 to identify the cause of the prolonged APTT, having established that they were not on any form of anticoagulants. However, if you look to the better right of my screen, you can see the majority of these samples, clotting times for APTT completely normalize with the second reagent, actin-FS, and the upper limit of our reference interval for this reagent indicated by the lighter blue line. And this is because of the higher phospholipid in this reagent overcomes these antibodies present in the patient's plasma, which are interfering with phospholipid binding, prolonging the clotting time with the reagent, which is sensitive to lupus anticoagulant. And we switched to a lupus insensitive reagent about 7-8 years ago, because it means interpreting the APTT is easier, because for the vast majority of patients, unless they have an extremely strong lupus anticoagulant, a prolongation of actin-FS for us, when there's no presence of anticoagulants, would give us the suspicion that the patient had a reduced concentration of the clotting factors 8, 9, 11, 12. And particularly with a patient who might have an APTT of 80 seconds, you would be concerned that they may well have a quite low level of factor 8 and undiagnosed hemophilia, an undiagnosed hemophilia A, hemophilia B, or von Willebrand's disease. So I guess for the laboratories you work in, identifying is your reagent sensitive to lupus anticoagulant or not sensitive to lupus anticoagulant will help inform your interpretation of APTTs. And I'm going back to the cascade because these antibodies will interfere with phospholipid binding indicated by PF3. So these antibodies will compete with these phospholipid binding sites that the clotting factor is required. And as they become less available, it will just take a longer time for the sample to clot when you're performing the APTT. And just to highlight, as mentioned earlier, that this is significant in APTT investigations, quite rare in the prothrombin time investigations. So these lupus anticoagulants are inhibitors, but we do have ways we can investigate patients with prolonged APTTs. When you're using a lupus sensitive reagent and you don't have an alternative, to try to distinguish a factor deficiency from a lupus anticoagulant or fast acting inhibitor. And this is by performing mixing tests. And you can perform this test immediately after finding an elevated APTT to help narrow down the possibilities of what causes prolongation. And as mentioned, lupus anticoagulant are autoantibodies directed against phospholipid binding proteins, mainly beta-2 glycoprotein 1, prothrombin, and some of the phospholipids, anti-PS, anti-PT. And this complex competes for clotting factors for the phospholipids necessary for clotting. So what you can do is mixing studies, and the document I mentioned earlier from WHO talks about normal plasma. In the UK, you may well purchase a commercial material for this normal plasma, or you can bleed normal donors. So these are people in your laboratory or in your institution who have a normal clotting time, aren't on any form of anticoagulants. you create a pool of donations of, let's say, 20 donors. Where possible, you would check that the clotting factor level of this pool was greater than 80% normal, so greater than 0.8 IU per mil for factor 8, 9, 11, 12, and freeze this material down at less than -24, preferably at a lower temperature, to use for these mixing studies investigations. And this is what's called normal pool plasma. And what happens is you would perform an investigation a second time after you identify a prolonged APTT. You mix one part of your patient sample and one part of the normal pool plasma and perform the APTT as before. And what should happen that if you have a clotting factor deficiency, the normal clotting factors from your normal pool plasma will normalize the clotting factors to a level where the APTT will correct to either within your reference interval or close to your reference interval. However, if there's an inhibitor present, then the inhibitor properties of these autoantibodies will maintain, and they will still interfere with the phospholipid binding proteins and still cause you a prolonged clotting time. So as I said, you're going to perform the same test again with the same reagents using the same APTT you did. Normally mix 1 part plasma from your patient, 1 part normal pool plasma, give it a quick mix, and then immediately perform the APTT as you've already done. And I'll get to shortly about incubated mixing, where sometimes there are fast-acting and slow-acting inhibitors, which may indicate hereditary deficiency or acquired factor VIII deficiency. And I'll just get to that in a couple of slides. So this is the kind of thing you may see. You have performed a APTT on your patient and it gave you an abnormal clotting time of 60 seconds. Let's say for argument that the upper limit of your reference interval was 30 seconds. So it's quite prolonged. Your question is this prolongation, once you've ruled out anticoagulants, due to a factor deficiency or potential factor deficiency or lupus anticoagulant? Your APTT control, this is your normal pool plasma, has an APTT of 35 seconds, so it's normal. When you mix 1 part of your patient plasma, 1 part of your normal pool plasma, and repeat the APTT, you get a correction from 60 seconds to 42. This is a good correction, so there's probably a factor deficiency present. However, if you do the mixing investigations and you get very little or no correction, this is suggestive that there's an inhibitor present. And this is a kind of pattern of mixing you would see when you have low levels of factor 8, 9, 11, or 12. You should see a prolongation of the APTT, recognizing the various APTT sensitivities to factor deficiency, which will correct with normal plasma because you're replacing the missing clotting factor, which will normalize the clotting time in the APTT. However, if you have an APTT sensitive reagent, an APT and then a lupus anticoagulant sensitive reagent, you'll have a normal APTT which doesn't correct with normal plasma. And this is just a worked example from the literature. This was a 7-year-old girl who suffered gastroenteritis for 3 days. She had a sample taken a couple of weeks later as part of a general checkup before a preoperative tonsillectomy. The prothrombin time was normal, but the APTT was significantly prolonged at 65 seconds. And we have 3 scenarios here, A, B, and C. If we just look at this top column, the APTT with a 1 part mix of patient plasma and pooled plasma. In scenario A, we saw no correction. So this will be indicative of a fast-acting inhibitor like lupus anticoagulant. Scenario B, you saw significant correction with a reference interval of 28 to 35 seconds for APTT. It's back within reference interval, suggesting that this patient has a factor deficiency. And there's a third scenario, scenario C, where again you see an immediate correction of the patient's APTT. However, you can also, to elucidate lupus anticoagulant from things like acquired inhibitors to factor VIII, acquired hemophilia as it's known, incubate the sample for up to 2 hours in a water bath at 37 degrees C. So incubate a second mix of your patient's plasma, one part normal pool plasma, and then after the incubation, repeat the APTT. And then you can identify that the APTT is still prolonged in scenario A because the fast-acting inhibitor lupus anticoagulant is still present, still inhibiting the phospholipid binding proteins. You can see in scenario B where you still see a good correction of the APTT, and scenario B where you had an immediate correction because the slow-acting autoantibodies were interfering with factor VIII were immediately corrected by the factor VIII in your pool plasma. However, after incubation, these autoantibodies interfered with the donated factor VIII and then caused a prolonged APTT. So it's one way of distinguishing factor deficiency, lupus anticoagulant, fast-acting inhibitors, and some slow-acting inhibitors invariably acquired factor VIII autoantibodies. Fibrinogen is the third investigation that we perform routinely in our laboratory. Fibrinogen is a 340 kilodalton glycoprotein. It circulates at 200 to 400 milligrams per deciliter, and it's cleaved by cleaving of fibrinopeptide A by thrombin initiates the polymerization of fibrin, which converts it to a insoluble polymer in the blood. Now, if you have access to automated analyzers, one of the advantages is the idea of a derived fibrinogen. This is where changes in light scatter and optical density during clot formation can be used to work out the concentration of fibrinogen. So during the prothrombin time, the change in light scatter is compared to the fibrinogen level, and the result is extrapolated from a calibration curve. And there's a good linear relationship between the derived and Klaus fibrinogen, except that high concentrations above 10 grams per liter or low concentrations, or in particular disease states like dysfibrinogenemias. So what you just see on an autoanalyzer as we see a change in light scatter over time. So when we perform the prothrombin time and we mix our thromboplastin with the patient sample, as the sample clots, you will see a change in light scatter as light is reflected and refracted off the generated clot. And the analyzer will convert this change in light scatter to a concentration of fibrinogen. And for many years, our laboratory was using this essentially free test from the prothrombin time as a measure of our fibrinogen concentrations. However, although there's good linearity or good correlation between derived and Klaus fibrinogen in things like DOC, thrombolytic drugs, dysfibrinogenemias, that relationship breaks down. So now we use a Klaus fibrinogen on our autoanalyzer in our laboratory. I know I'm running slightly over, so I only got a few more slides just to talk about reference intervals, because you have an APTT, but you need to then compare that to a normal reference range to decide if this APTT is prolonged. In our laboratory, we would recruit 20 healthy normal donors. This is often people who's working in the laboratory or the surrounding institutions, people who are healthy, aren't on anticoagulants. And then when we change to a new batch or lot of APTT reagent, or we introduce a new test, or we change the technique by changing analyzer, we would perform 20 APTTs on the patient using the same process as we did for our investigating patients and generate the clotting times. We would then plot this data and look at the plus and minus 2 standard deviations. So you look at the central 95% of patients and remove 2.5% at the lower and the higher end. And you're assuming the patients have a Gaussian normal distribution. So you end up with something like this. Most of your patients will fall within the 95% target. And we established a mean value of 30 seconds, the standard deviation of 2.9. So plus or minus 2 SDs gave us a reference range for APTT of 24 to 36. Any APTTs above that, we would consider investigating for an explanation of that why that clotting time is prolonged, unless there is already a known explanation like anticoagulation, like liver disease, for example. And finally, to finish up, you have your reagents and you're doing your investigations and you are performing a reference range. There's also the idea of quality assurance, the term to describe all the measures taken to ensure accurate reliability laboratory results. So it's looking at the choice of tests, the analyzer, the methods, the interpretation of results. This commonly falls into internal quality control and external quality control. IQC ensures precision and consistency of results. EQA is a retrospective analysis comparing results between laboratories and between methods, and often there's an external organization available for laboratories to participate in, so they can compare their performance against other users. And IQC looks at precision, so it's required to ensure results are precise and consistent over time, day to day, whereas EQA is looking for accuracy to confirm agreement with other users and gives you confidence in what you're doing in the laboratory when performing PTs, APTTs. If you're going to be doing quality control, the material you should use as a substance used in routine practice for checking the concurrent performance of the analytical process. So it should be similar in properties and be analyzed along with your patient samples. So essentially it should be a plasma material. This can be commercially brought, or in our laboratory, we create our own internal QC, which is slightly more time consuming, but is possible. And the QC material has a similar property to the test sample. On automated platforms, you can see the data displayed, or you can keep a written record of the results and the interventions when the QC is out of target. So this is slightly old data, but this is a plot of the APTT for our IQC material over time. And we have a ±2 standard deviation acceptable target. And when results are outside of that, we would perform additional investigations to identify the cause of the prolonged APTT. And this might be suspend new patient testing and reporting until we understand what caused the abnormal results. First, we retest the QC to exclude analytical error. If that's still out, we replace the QC material and retest. If the APTT is still outside the reference range for QC, we replace the reagent and retest. And if it's still abnormal, we suspend testing because we're not sure about the underlying cause of the issue and switch to a backup or consult colleagues to provide some insight and support. So to finish my lecture, I just conclude on a few points. Reliable coagulation screening can be performed with automated and manual methods. These tests can be used successfully to identify bleeding disorders or risk of bleeding preoperatively. Worth remembering that a normal APTT can't rule out mild haemophilia A and haemophilia B, that lupus anticoagulant can interfere with APTT, but that's reagent dependent. Mixing studies can distinguish between bleeding and lupus anticoagulant patients. Reference ranges locally derived are needed to identify abnormal results. And IQC and EQA are important in maintaining good practice. I'd like to thank you all for your attention, and I'm happy to take any questions or comments. If I scroll back to the beginning, my email address is available here if anybody wants to contact me. And if the organizers want to share the slides, I'm happy to forward them on to my colleagues who can pass them on to yourselves. Thanks for your attention.
Thank you, Kieron. Very interesting talk. Does anyone in Zambia have any questions for Kieron? No.
If not,
yes, I do.
Oh, sorry, yes.
Go.
Hi, thank you so much for the talk. That was very informative. So I wanted to ask about that slide that you listed, some sample variables that affect Is it PT? You talked about polycythemia.
Yes.
Yeah, I wanted to find out how exactly does polycythemia affect the results?
Yes. So often it's difficult to identify the patient with polycythemia unless either A, you can visually inspect the patient sample, and when you've centrifuged the sample, you can see a quite high hematocrit and therefore a lower volume of citrated plasma, or you can consult the haematology records if they've had a full blood count and they may have data on the polycythemia. But as I mentioned, what we're looking for is 9 parts blood to 1 part anticoagulant. So in most patients whose hematocrit is less than 55%, that's okay. But above that, you end up with a packed cell volume much higher in the sample tube, and then a citrate plasma, which is no longer 9 parts blood to 1 part anticoagulant. It now may be 5 parts blood to 9 parts blood to 3 or 4 parts anticoagulant. So there's too much anticoagulant in the citrated plasma because there's a much larger packed cell volume and less citrated plasma to test. And in that scenario, we generate what we call an adjusted citrated bottle. So in a separate tube, we would adjust the concentration of sodium citrate in this special bottle, which is essentially just a polystyrene tube. Then the phlebotomist would draw the sample to 4.5 mils, and we've adjusted the anticoagulant to compensate for the polycythemia. So when the sample's centrifuged, the concentration of blood to anticoagulant remains at 9 to 1. So we have an appropriate amount of sodium citrate in our plasma, and then we can perform the laboratory investigations, because we have seen in the past that polycythemic patients can have extremely deranged clotting time, which bear little resemblance to their true clotting because of the high hematocrit in the patient. And if I go back to this document and also the 2 documents from the International Council from Standards in Haematology, go into a nice clear description of the algorithm or formula, for readjusting the amount of citrate you put into a tube to compensate for the polycythemia in a patient. So when you then do that and perform the PT and the APTT, you get the correct clotting time on that person.
Okay, thank you. That makes sense.
Thank you. Anyone else got questions?
Can I ask
Good
just for my...
afternoon.
Yeah,
Sorry.
go ahead.
I just want to find out, you mentioned something related of prothrombin time to antiphospholipid antibody. Could you please just emphasize this again? Because we know that antiphospholipid antibody is mainly related to the PTT, unless I missed the point.
No, you are absolutely correct. You will majority of the time see the influence of the antiphospholipid antibodies interfering with lupus sensitive APTTs. I was just highlighting with the prothrombin time, there are small cohort of patients you may see with either a very strong lupus anticoagulant or particular autoantibodies in their lupus anticoagulant or in that patient, which can interfere with the prothrombin time. I will say it's extremely rare. We have in our laboratory an anticoagulation clinic for patients who are on warfarin. We only have 2 patients, so a tiny proportion of the patients who are on warfarin, who we have to monitor their prothrombin time using a reagent which is much less sensitive to lupus anticoagulant because that's a higher phospholipid. So we replace our routine prothrombin time reagent Innovin with a different reagent, Fomber-LS, for this couple of patients we have, to ensure that when we perform the PT and we convert it to INR, that these autoantibodies aren't interfering with prothrombin time. But it is, as you mentioned, more common or most common in the activated partial thromboplastin time, but we can, on rare occasions, see it in a prothrombin time. So I guess it's the highlight that if you have abnormal prothrombin times, one thing to consider in the back of your mind is, yes, it most likely may be the patient has anticoagulation they haven't diagnosed, so they're on warfarin and they haven't mentioned it, or it's liver disease, or obviously it's a factor deficiency, but it's potentially could be still an autoantibody interfering. And sometimes these autoantibodies are not just due to lupus anticoagulant, but sometimes the patient will develop autoantibodies. One example from our laboratory was a patient, and again, this is a rare occurrence, kept rabbits, and he developed a rabbit antibody inside his body. So when you were performing a prothrombin time with a reagent which is based on rabbit thromboplastin, so it's animal-based reagent, which is still available, this interfered with his prothrombin time, and a different reagent had to be used for performing investigations. So I guess the message for PETs is there are rare occasions when antiphospholipid antibodies or other autoantibodies may interfere with the phospholipids in your reagents or the binding sites that these phospholipids are trying to attach to, which can prolong the prothrombin time. And it's just something to consider if you've ruled out other causes such as factor deficiencies, anticoagulations, etc.